If you have ever felt that the public story of menopause hormone therapy, MHT, has swung like a pendulum, you are not imagining. It was for a period promoted as good for you, then it became frightening. Now it's being presented again online as safe and even protective for your heart and the brain. Before we start, a quick note. This is general education, not medical advice. I can't tell you what you personally should take. Menopause decisions depend on your own history and risk factors, so please use this as a guide for questions to take to your own doctor. The truth sits somewhere in between. Menopause hormone therapy, or MHT, is not one single thing, it's a category. The balance of benefit and risk depends on the person, the timing, the dose, the delivery method, and the type of progesterone used. And most importantly, the reason you are using it. Once you understand that, a lot of the noise becomes easier to ignore. Let me start with Lydia. Lydia is 70. She remembers being told years ago, hormones are good for you. You should take them. So she took them. Then came the next message. Stop! Cancer! Danger! She stopped. Now she's hearing a third message. It's safe again, and it protects your heart and your brain. Her doctors say there's no real benefit starting at your age, at 70, but her social media messaging keeps repeating a very different message, delivered with striking confidence. So, what's the answer? What's the story? So, Lydia asks a very natural question. Who should I trust? This is where we begin. Not with slogans or blanket statements, but with a proper clinical framework for thinking. So, the first thing I would say to Lydia is this: your confusion makes sense because the advice really did change. It changed for reasons, not because doctors were trying to mislead women. Why did the messaging change? A lot of modern fear story traces back to a large study that is quoted constantly, often without proper context. 2 points matter. First, many women in that study were not recruited because they were suffering menopause symptoms and seeking relief. A significant number were older and many years beyond their final menstrual period. That matters because hormones can behave differently depending on the stage of life. The baseline health risks are different when treatment is started much later. Second, the products used then are different from what many clinicians commonly use today. Certain older oral estrogen preparations and some older synthetic progestogens have stronger clotting and vascular effects than modern transdermal estradiol and newer progesterone options. That does not make the study wrong. It means the public takeaway that all hormones are the same and all women are the same was far too broad. That's where the familiar guideline came from: under 60 and within 10 years of the final period. It is a practical safety framework, but not a magical line. It reflects a pattern seen across studies. Starting earlier in otherwise healthy women tends to be lower risk than starting much later, particularly when it comes to clot and stroke risk. Now, something important has changed in the menopause discussion, and I want to be clear here. This is not a recommendation for everyone to start hormones at 70 because they saw a confident video online. What has changed is the growing recognition that carefully selected women who are well past menopause may still benefit, and that modern way hormones are delivered can meaningfully change the risk profile. In other words, age alone should not be the only deciding factor, but the decision does need to be carefully individualized and reviewed over time. If Lydia was sitting in front of me, I would slow down and ask one question that online content often skips. Lydia, what are you hoping to improve? Is she still having hot flushes? Significant flushes that never truly settled from her perimenopausal years? Or is her bone density the main concern now? Or is she frightened of dementia and heart disease information she has seen online and wants hormones for prevention? Those are three very different conversations. They lead to very different decisions. Now let's talk about clear distinctions because that is often the best antidote to confusion. First, oral. Oral versus transdermal. Transdermal estrogen. This difference is not a minor detail. Oral estrogen passes through the liver first. That first pass effect can increase certain clotting factors and raise the risk of venous thromboembolism, the deep vein thrombosis and pulmonary embolus group of conditions. Transdermal estrogen, meaning gel or patch through the skin, that is slightly different. That tends to have much less effect on clotting because it doesn't need to pass through the liver. That is why many clinicians favor transdermal options when clot risk is a concern. When a woman is older, when treatment is started later, or when other risk factors are present. Second, progesterone is not just progesterone. If you have a uterus and you use systemic estrogen, you usually need or progestogen to protect the lining of the uterus. Different types behave differently in the body. Some newer options are often described as more neutral compared to the older synthetic progestogens in terms of breast and metabolic effects. But there is an important caveat. Much of the evidence is observational rather than from large randomized trials. Observational data can be very useful, but it's not the same as large randomized trials in their certainty and their conclusion. And lower risk never means no risk. Now let's address a common misunderstanding that has created unnecessary fear and guilt for many women. You must stop after 5 years. There is no universal stopping rule that fits everyone. Some women have hot flushes that persist for many years after. Some find that sleep disruption returns when therapy is stopped. Others are using treatment for more than one reason at the same time. For example, symptoms relief alongside bone support. If a woman is benefiting and is being reviewed properly, continuing care can be reasonable. The real principle is not 5 years and stop, not 10 years and stop, but regular reassessment to ensure benefits still outweigh risks at that stage of life. Now, breast cancer. This is the concern that dominates many discussions. So it deserves a careful explanation without minimizing and without catastrophizing. A sensible way to frame breast cancer risk is to begin with the baseline risk and then discuss how MHT, menopause hormone therapy can change it or may change it. In Australia, around 1 in 7, 1 in 7 women will develop breast cancer over their lifetime. In the United States, the commonly quoted lifetime risk is around 1 in 8. So much the same. 1 in 7, 1 in 8. And that's the baseline. Combined MHT, estrogen plus a progestogen, is associated with a small increase, small, in breast cancer risk. And that increase tends to relate to duration of use. It is rarely a sudden cliff. It is closer to a gradual increase over time. Two nuances are often misunderstood online. First, estrogen only therapy, used when the uterus is absent, has shown different patterns in studies, including no increase and sometimes even lower breast cancer rates in certain contexts. That does not mean estrogen only therapy is protective for everyone. It means the relationship between hormones and breast tissue is more complex than the headlines suggest. Second, when you hear the same progesterone types may be associated with lower breast cancer risk than older synthetic progestogens, keep the caveat in mind. Lower risk is not zero risk, and the strength of the evidence matters. Now, I want to say something that is both medically important and quietly reassuring. Lifestyle factors. Lifestyle factors often influence long-term health risk more than MHT does. Excess weight, low physical activity, smoking, alcohol intake, and chronic sleep disruption all affect breast cancer risk and broader health outcomes. These are not moral judgments, they are physiology. If someone is chasing perfect hormones while ignoring these factors, attention has shifted away from where the biggest gains usually are, these lifestyle factors. And finally, a practical point that sounds mundane but genuinely changes outcomes. Menopause care takes time. A good consultation is rarely a rushed one. It requires space to understand your current symptoms, including those many women do not volunteer unless asked directly, like genital and urinary symptoms, mood, libido, sleep, as well as the past story. The past story, why treatment started, why it stopped, what changed. That context matters as much as the prescription. That is part one. If you're encountering multiple and conflicting messages online, don't chase the loudest one. Use this as a framework to talk things through with your own doctor, because the safest and most effective choice depends on you. In part two, we'll look at why perimenopause feels so unpredictable, why blood tests can mislead, and why the 40s can still hold some surprises.